Why is direct observation important in competence by design? In competence by design, competency involves more than know-how, it requires the trainees show how and demonstrate ability to do independently. Therefore, faculty should be able to critically observe, question, and judge trainee performance in actual patient care situations. Adults learn best when they can reflect on experience, consider steps to improve performance, then put those lessons into practice. Pilots, teachers, and even hockey players use this approach. Trainees practice their skills in front of a more experienced colleague, receive feedback, make improvements, and then continue the cycle. How often do we observe our trainees? Trainee anesthesiologists are rarely observed by their teachers. Less than half of medical students recall ever being observed conducting a clinical encounter. Even when faculty and residents share a clinical session, less than 5% of the total amount of time involves direct observation of resident performance. Whatever observation does take place is more likely to be focused on procedural skills and final results rather than patient-provided interviews, professionalism, newer competencies acquisitions based on practice or interdisciplinary teamwork. Indeed, for many anesthesia residents, the most intensive observation does not come until the end of training, seated in front of an examiner in a final examination.
All right.
Oh, okay. Is it done now?
Yeah, all done. Yeah, no problem.
Oh,
Yeah.
nice. Good job, eh?
Yeah, thanks. Anything to comment on?
Well, it went in, so it must be perfect. Hey, great job. Well
Great.
done.
Thank you.
How can we incorporate direct observation into our assessment? The good news is that direct observation can be acquired by frontline teachers, but faculty members must acknowledge their importance. Successful direct observation needs planning and attention to context. Here are the steps that we can take. Step 1. Make direct observation part of the culture of the practice. Choose a specific skill, behavior, or process to observe in your encounter with the resident and communicate the goals that should be accomplished even if a formal assessment by the resident has not been initiated.
Oh, hi Sandy, how are you today?
I'm doing good. So I have a question. It looks like we are in an ortho room today, and I was wondering for today if you can evaluate me on the EPA related to patient positioning on sitting position.
Sure, that should be fine. Did you already enter it in the e-portfolio?
Yeah, I already sent the request for you, so I think all you have to do is accept it.
So I'll go in and do that, and then we will do the EPA for the patient positioning.
Okay.
Step 2. Prime the patient. Patients need to know what to expect and be given the opportunity to give consent. Step 3. Prepare the learner. It is helpful to mention the issue of teaching by observation the first time the learner and teacher meet. It is beneficial for residents to know how many skills will be observed, when the feedback is coming, and what information, if any, will be sent back to the educational program.
Hi, Dr. Deer.
Hello.
We're working together today.
Oh, are we? Excellent. So I think today the EPA would be consent.
Okay.
Okay, we would do consent, and the main emphasis would be on communication and how we talk about the procedures and risks and benefits to the patient. We will go over different scenarios, and at the end of the day we can talk about how the day went and give you feedback for that.
Okay, that sounds great.
Excellent. Good.
How can we improve our direct observation skills? We can emphasize 3 main strategies to train ourselves in behavioral observation. The first strategy is simply to increase the number of times a resident is observed. This helps to improve recall of performance and provides multiple opportunities for skill practice in observation by the faculty. Practice makes perfect. The second strategy is to have a form of observational aid that we can use to record observations, sometimes referred to as behavioral diaries or aide-de-memoire devices. Every day we should strive to write down at least one thing the resident has done well, one thing he or she can improve, and a plan to help him or her. It takes 5 to 10 minutes to enter these notes into a simple Word document on the computer. By doing this on a regular basis, we have a rich source of observations that we can simply cut and paste with a little editing into the ePortfolio final evaluation form. The third important strategy is to learn how to prepare for an observation. To prepare, we should determine the objectives or goals of the observation before entering the patient's room with the trainee. Other aspects of preparation include the following. How should we position ourselves in order to ensure proper technique is used by the resident? How and when will we confirm, if it is necessary, the security and accurate execution of the procedure by the resident? This preparation helps to maximize the effectiveness of the observation. Remember these simple rules. Number 1. Correct positioning. As the evaluator, try to avoid being in the line of sight of either the patient or resident, especially when they are communicating. Use the principle of triangulation. However, during procedures, be sure that you can view the trainee's techniques accurately. Number 2. Minimize external interruptions. Let your staff know you will be with the resident for 5 to 10 minutes. Avoid taking routine calls, etc.
That seems like a good spot. Small poke, okay? 1, 2, 3. Okay.
Hi, how are you doing?
How are you?
I'm good, how are you?
You're doing very well.
Number 3. Avoid intrusions.
Hi there, Maria. My name is Zach, one of the resident doctors of anesthesia. I understand.
Don't interject or interrupt if at all possible. Once you interject yourself into the resident-patient interaction, the visit is permanently altered.
I think it's something that we should do is an awake intubation. Okay?
What he means to say is that sometimes it can be hard and challenging for us to get that tube down the throat. So what he's trying to describe is what are the alternatives and what's probably the safest way to do it.
Okay. So what's involved?
However, there will be many times at some point in the encounter where you need to interject yourself in order to correct misinformation, assure patient safety, etc.
So one of the first things we do is make sure that your entire mouth and back of your throat is numb with local anesthetic solution.
Well, he's basically trying to refer to the freezing medication that you often have when you go to your dentist. Remember that? Okay.
Okay. So we do that using multiple different techniques. So we use a spray in the mouth to get the area all frozen. Okay. We also soak some gauze in local anesthetic, the freezing, and put it at the back.
I think, before that, we're going to get you in the room, put all the monitors on, we are going to get the IV in, and only then start all the things that he's describing, because there can be some side effects,
Okay. So of course, yes, absolutely. I should have mentioned before that we will get you.
Number 4. Be prepared. Know before you enter the room what your goals are for the observation session. For example, if a perioperative evaluation is required for an ASA 3 patient scheduled for an emergency laparotomy, have the resident present the history first. Then you will know what are the key elements to observe during the consult. Number 5. Be learner-centered. Ask students what they would like to focus on before beginning the session. The closer the teaching matches their needs, the more likely it is to be effective. While it is tempting to orientate sessions around therapeutic tips and medical facts and figures, direct observation is best suited to the teaching process rather than content. Try to focus on patient-centered skills, techniques for improving performance during procedures, and ways of dealing with challenging situations. For example, potential complications, alternative anesthesia plans for specific patient, hemodynamic goals, etc. Given sufficient preparation, focus, and time for reflection, direct observation is the best teaching tool we possess. Although it demands organization and commitment, it can be as meaningful for the teacher as for the learner. The core of great direct observation allows teaching to move away from familiar, comfortable routines to a dimension that depends on and reinforces the relationship between the teacher and the learner. Remember to visit our website to access more videos and information about the CBD implementation.